Hi, I'm Tony Bordenaro, respiratory therapist here at Eureka Springs Hospital, and we have a new piece of equipment that I'd like to teach you about today. It's a capnographer / pulse oximetry, which that part we know already, and it's able to be used two ways with a nasal cannula or an ET tube. Most likely you won't be using it with the ET tube, the respiratory therapist or EMTs will be doing that, but we can be using the nasal cannula in the ICU or any patient's room, and that would be handy for us to use. The reason that we use the capnography, it saves some patients the having to get an ABG to find out their CO2 and their SpO2, and it's a lot less painful. What I'm going to teach you today is where the machinery is going to be kept. It will be in the crash cart. All right, let me show you where it's kept in that crash cart. We're keeping this in here for security purposes. And we won't only be used during the code, we'll be using it for patients on the floor. It's down in the respiratory section of the crash cart. It'll be plugged in, but it can be taken out. It holds a battery for about 10 hours, so it doesn't need to come with doesn't need to be plugged in while we're using it. It has pulse oximetry just like we're used to using. And we also have all these melt core that fit in this machine, all these adapters for the self-adhesive SpO2 sensors. And they'll be kept down there also. Okay. This is the special Smart Capno Line plus O2 nasal cannula that we have to use with this machine. And it works as a nasal cannula. We'll put it on Kim right now. It has a special, where the CO2 is sensed, is down here that goes near the mouth. And otherwise it gets put on like normal. Sorry. And we'll put Kim on 1 liter because she's not looking so good. The other end of it here is for the CO2 sensor, and it gets screwed. This is the machine, this is the screen. Up on top, it gets screwed very simply, clockwise, 2 turns. It's got to be tight, but not that tight. And that's basically it. That's how we set it up. All right, so we have the oxygen turned on. It's placed on the patient properly. We have the pulse ox on her finger. And then we're going to turn the machine on. It's just up on top. There's a little switch. Flip it, and it will do a self-test, which will sound like that. It takes a few seconds to run through that. It says now the CO2 is on, the SpO2 on because it's properly on her. And in a few seconds we should see a readout up here. I think it takes 1 minute before it reads out for the first time. End-tidal CO2 and the SpO2. The beeping that we hear is kind of interesting. When the SpO2 is higher, it'll beep at a higher pitch, and when it's lower, if it was going into the 70s or something, you hear beep, beep, beep. It'll go a lower pitch, which I thought that was kind of neat. The end-tidal CO2 will generally be between 25 and 35, and naturally the SpO2 above 90. There's no, in case it was alarming, it has alarms that are set already on this, so you don't really have to play around with that. But if it should be alarming, there's an alarm. Well, actually, if Kim stops breathing for a second, we might hear an alarm, and I can show you how it turns off. She's holding her breath right now. She hasn't really stopped breathing. And we should hear an alarm soon, hopefully. She's turning blue now. The CO2 is going down. Okay, come on. Okay, that's the alarm. And you can silence it with that button, which you don't really, you want to see what the problem is if the alarm's going off, but there is a silence button on here like that. Right now, if you hyperventilate, which is going to do a little bit right now, you should be seeing the end-tidal CO2 going down. It's down to 28 right now. And that would be the case also if you were bagging a patient that was intubated. You'd be she's down to 20 right now. Okay, you can stop there, that's great. And her oxygen at 100%, but if you're bagging, you want to keep it between 25 and 35. And if you were bagging too fast, you'd see it go down to 20 like she was just doing right. In a lot of instances, we might want to keep that CO2 monitor and this with the patient overnight in the ICU to see how things are going. And as long as you can't use humidity, you can't humidify the nasal cannula. As long as there's not too many secretions, we should be able to keep it on overnight. If there's a lot of secretions going on, or somehow it gets wet.
In though, right?
Yes, you'd have to have it plugged in if you're going to use it for overnight. It lasts about 10 hours without being plugged in. So you probably need to plug it in for nighttime use. I guess now we'll talk about how to use it with the ET tube. We'll have to intubate Kim. The other purpose for using this capnography would be if a person's just been intubated, we might want to see if the readings between 25 and 35 is placed in the right place. If not, it might be showing that it's in the esophagus. And we use a different line for that. This is called a filter line set. It doesn't get hooked up to the oxygen naturally because the person's been intubated, like Kim has been right here. She's doing pretty well. She's wide awake and she's not even under any stress. This end of it gets placed on the capnographer the same way. Well, I have to turn it back on again. It'll run through the self-test again. And in the meantime, this just snaps on in here and one turn. It's not blind. There we go. Can you hold that, Kim? Since you're intubated and can't go anywhere. And this piece just snaps on over the ET tube, and we'll be bagging with an ambu bag that will be placed on that side, and we can keep bagging that way. And let's see how Kim is doing here. She's reading 30, so we're bagging perfectly. She doesn't have any oxygen showing, so she might be in a little trouble, but we'll have to turn the oxygen up a little bit. Okay, and that's basically it for the ET tube section of this. Well, first of all, in review, I think there's probably a good idea for all of you to get with Scott or myself or Bonnie and go over the machine so you can see it in person and actually play with it yourself so you'll feel better with it in case an emergency arises. We can show you exactly where it is and how to turn it on. You can use your own fingers and see that for yourself. In review, it's going to be in the crash cart. It's going to be plugged in. You can detach it. When you get the nasal cannula will also be down there. The sensors for the pulse ox will be down in the crash cart, and we'll also leave some little books that talk about how to use it down there. Plug up the nasal cannula. If you're using a nasal cannula, plug that into the wall, turn it on. You can't use humidity with it, and remember there's only one spot where you can put in the sensor for the CO2. That will be up here. When you turn it on, it's going to do a self-test. And then after that, it's really pretty much self-explanatory. We want to make sure it stays between 25 and 35. And if we use this properly, it'll save some patients the pain of going through an ABG. That's just about it. Thank you. The other use for this capnography is when somebody's just been intubated to see that it's in the right place. If it's not between 25 and 35, that would be an indication that it might be in the esophagus instead of the trachea. Let's do that again.
Go ahead.
And
start over.
Okay. Oops. She's been extubated. Who's that good producer? Steven Spielberg. Oh, still on. Let's see what else I can tell you about this. Any suggestions?